The elastic score 5 demonstrates no strain over the lesion and also includes the surrounding areas. And is depicted as blue, and it's often or most of the time seen with cancers, which are usually the lower or mid-grade cancers, which tend to have desmoplastic reaction. This is a nice example of the lesion, which is very irregular with posterior shadowing, and when you look at the elastogram, the actual blue area is larger than the one depicted on B mode. This was grade 2 invasive ductal carcinoma on core biopsy. Malignant lesions tend to be larger on strain images than on corresponding B mode images, potentially because of the surrounding desmoplastic reaction that accompanies most of these malignancies. And that's what we would see on the elastogram, a lesion which appears larger than on B mode. There are certain studies that have been performed. One of them is by Dr. Ueno himself, and he has found that most malignant lesions are have either a score of 4 or 5, and then he has not found one malignant lesion associated with a score of 1. Most benign lesions are either 1 or 2, and his results showed that elastography showed a sensitivity of 86.9, specificity of 92.1, and an accuracy of 89.8%. There is a multi-institutional or multi-center clinical trial that was performed in Italy, and these findings of this trial were presented at RSNA in 2006. 874 lesions were evaluated. 614 were benign and 260 were malignant. The evaluation with real-time elastography showed a very high specificity in benign lesions, including BI-RADS 3 lesions. The negative predictive value was 98% for all the lesions and 96.3% for all the BI-RADS 3 lesions. Real-time elastography does help conventional ultrasound in characterizing breast lesions. There is a French multicentric prospective study utilizing 345 lesions in patients in 314 patients. This was presented at the European Congress of Radiology. Elastography for the lesions of all sizes achieved sensitivity of 80%, specificity of 93%, and positive predictive value of 85.3%. The negative predictive value was 90.3%. What's interesting about this study is that the sensitivity was best for lesions that were less than 5 millimeters, which is very helpful because those lesions are not well evaluated with B mode. So this is a great tool to help further characterize these lesions. There is also a study that was conducted with the Italian group led by Dr. Martina Locatelli, was presented at the European Congress of Radiology in 2007. It was a multi-center study, and the study demonstrated a negative predictive value for BI-RADS 3 and 4 lesions to be 98%. And again, interesting finding, lesions that were less than 5 millimeters, the negative predictive value was 100%. So in conclusion, the real-time elastography helps conventional ultrasound in characterizing breast lesions. Complementary sign, it is a complementary sign to the B-mode imaging, and it's highly specific for BI-RADS 3 lesions, and it decreases false positive biopsies. Elasticity imaging may eliminate the need for biopsies, resulting in significant cost saving for the health service. Currently, about 80% of breast lesions biopsied are benign, according to the American Cancer Society. A large multi-center study is needed to validate these findings and to determine accuracy of this imaging technique. I would like to present you with a case of a 59-year-old female with an invasive ductal carcinoma in her right breast and a suspicious right axillary lymph nodes that were documented on MRI. This is the B mode and the elastogram of this lesion, and it has a score of 5 because the lesion on B mode, on the elastogram appears larger than the one on the B mode. So it was given a score of 5, and the biopsy demonstrated a cancer. But because the lymph nodes were abnormal on MRI and ultrasound was performed, and we were trying to decide based on ultrasound imaging whether these were abnormal lymph nodes. So we could not determine from just grayscale imaging whether this is benign versus malignant. Using the short to long axis diameter ratio, in which case, in this case, which was 0.53, which was greater than 0.5, Dr. Lishik has demonstrated that most of these lesions would be metastatic lymph nodes, 75%, but 18% of those could be benign. So ultimately, you need to perform a biopsy. And since we were studying the actual mass with the elastography, we then decided to also investigate the lymph node, and it shows a classic score 4 lesion, which is consistent with a malignancy. Since ultrasound cytology can yield false negative results, elastography seems to have a potential to improve that accuracy of percutaneous biopsy. In our situation, when we biopsied that node, the results came back metastatic carcinoma, and basically it staged the patient, and she did not have to go through the sentinel lymph node. And as a result, again, we are trying to reduce the cost of medicine by performing these procedures. So this also seems to have a great value, especially in breast imaging. Possibly in any other cancers that are often the lymph nodes are evaluated would be melanoma, and we may be able to perform elastography on these lymph nodes and maybe make a decision whether we should biopsy them or not at that time. I thank you for your time.